Thank you, Mr. Chairman. Thank you, GIS. It's always great to be with you guys and great to see GIS thriving with their valves meeting for the second year. So this is the afternoon session. I'll try to keep this quick. This is a 76-year-old gentleman, hypertensive, heavy smoker, presented to our center with non-STEMI, had a PCI to the right coronary artery during that session. And 2 days later, we were stuck in the ITU. It's severe mitral regurgitation. We put him on an intra-aortic balloon pump with some improvement, but this was what the echo was looking like. And you can appreciate, I don't think there's any doubt about the severity of MR. It's the mechanism that we were battling with. The jet really points towards potential. So in this direction, it can either be limitation of motion of the posterior leaflet or prolapse of the anterior leaflet. However, we can't really discern, we can't see it even in the long axis views. I mean, there's a hint of an A2 prolapse, but we're not entirely sure what the mechanism was. This is why we had a TE done. And the TEA confirmed that there's hardly any restriction with the posterior leaflet, very mild in all honesty. But with a sweep, you could see that P3 was slightly restricted, but the main mechanism here was prolapse of A2. However, and this is one area where 3D echo is unparalleled, there is a deep cleft-like indentation in the posterior leaflet. And it was interesting to see, this is the color 3D, just to understand that the regurgitation has a double mechanism, essentially. So we had a heart team meeting, and the problem was, as we were doing that, the patient was going into repeated bouts of pulmonary edema. He initially showed very good response with the intra-aortic balloon with some stabilization, but then once the balloon was out, it was congestion, congestion, congestion. In parallel, worsening renal function, and because of the fact that this was a recent MI, a relatively frail individual, and an EF of 40% in the presence of severe MR, our surgeons weren't entirely happy about taking this guy to surgery. So given the high surgical risk, it was transcatheter edge-to-edge repair. And we had our technical concerns to think about. It's a complex MR mechanism with A2 prolapse, some mild restriction of P2, P3, a deep cleft-like indentation in the posterior mitral leaflet. So from an embryological perspective, I wouldn't say a cleft as such. And the only solution to deal with that is sort of a convergent clipping strategy. So that would be an off-axis P3A2 clip rather than there is no P2 as such with an XTW. And if that sorts it out, then we're probably happy. If not, a second clip in a convergent fashion for a P2A2 grasp if needed. And you can obviously see I'm not great with artistic work, but this is how essentially we wanted to look at the end of the procedure. And this was sort of our regular workup with mitral clips, and on the whole, we didn't have any concerns apart from the complex mechanism, but in terms of the mitral valve area, in terms of leaflet length and so forth, it was pretty much straightforward. So we proceeded as planned, a bit of an off-axis first deployment, getting P3 to A2. And you can see that we ended up with a reasonable result in terms of how the clip is situated. So it's getting the medial side of P3, anchoring it to A2. We transformed a somewhat functionally tri-leaflet valve to a functionally bicuspid valve now. And you can see on the color 3D that we're still getting a bit of regurgitation. You can still see that the mechanism here is mostly related to, there's a tiny central whiff. I think that's one residual leak through the cleft itself, but you can still see that eccentric regurgitation related to the A2 prolapse. So with the residual moderate MR, it was time for a second clip. Our gradients were mean of 2 and a peak of 5 at the time, so we weren't really concerned. So that was the second clip, and you can see that the second clip is not exactly perpendicular. Slight change in the angulation with the TOE probe, and we can see that this is slightly convergent on the angiography screen. This was an NT clip, and we didn't think we would require anything more. I think with a very good result at the end of the procedure. So that was how the leakage looked like. The good thing, which I don't have the hemodynamics, the V wave went down from 60 millimeters mercury to 12, which we thought was fantastic. And we only ended up with a mean gradient of 2 millimeters of mercury. And if you look at the color or the 3D images, both from the atrial and ventricular sides, we were able to achieve exactly the sort of final anatomy we want, with mostly a single large lateral orifice and almost complete obliteration of the medial part, medial to the cleft itself. So hospital course afterwards was actually quite smooth. We completed revasc a couple of days later for a residual LAD lesion, and the patient was discharged happy 3 days later. So I think a very quick couple of take-home messages would be, I think understanding, and it's similar to anything we do with complex interventions, really understanding the mechanism of MR is always critical to success. And obviously pre-procedural planning. With planning, my 2 cents on it would be it's a process where the entire team really has to take place. So we were discussing the plan. We haven't done clefts before as such, so we were discussing the plan with the entire team, including surgeons or echocardiographers. But the plan also has to be clear, it has to be tailored, and it has to be dynamic. So we do have a plan, it's solid, but obviously, during the procedure, if you have to revisit the plan, you should have it sort of figured out in advance. Thank you very much.